Hey guys, good afternoon, everyone. Can you hear me well? All right, so we'll be talking today about a couple topics. Um, should we wait for anybody else?
I'll send a text reminder.
Um, if is all right, we'll start with you. Okay, so Victoria, you asked about Cialis and Viagra for the Viagra for nursing home patients. There's really no need for any kind of workup prior to using these medications. The only issue is you can't use these medications with nitros at all. Any kind of indoor isosorbate mononitrate, isosorbate dinitrate, and if somebody who's using PRN nitroglycerin, they need to be educated that within 24 hours, these medications can't be used. There's still black box warning, did not really change, and there's exaggerated vasodilatation, hypotension, syncope, and arrest associated with combination of these medications and nitroglycerin. And this is why we have to be careful. Otherwise, you can really use these medications. The validity and the usefulness of medications such as Viagra and Cialis in the management of pulmonary hypertension is really marginal. But I don't think it's a bad idea for us to try them in certain patient populations, especially if they have pulmonary hypertension in the settings of severe tricuspid regurgitation. As you know, the elderly people, they have incompetent tricuspid valve, and most of the time it's associated with pulmonary hypertension and bad lungs. Any questions about that?
Thank
Well, somebody asked about PFOs. There's some weak association between PFOs and migraine headache in ladies in general. There's association between PFOs and cryptogenic stroke. The treatment PFOs don't really leave a significant shunt that the shunt is going to affect heart function and create symptoms of heart failure. ASD can do that, but PFOs should not. PFOs are very prevalent. 10 to 15% of population will have certain degree of PFOs. The only way that I would be concerned about PFO, and I would encourage discussion about closure of a PFO if somebody under the age of 40, especially women, gets cryptogenic stroke that you can't identify the etiology. In that case, it's not unreasonable for you to refer for PFO closure. I've never done that throughout 10 years of my practice. So you would take it with a grain of salt. The PFOs did not really make it to the guidelines in terms of class 1 indication, or even class 2A indication, and the treating something that you really are not aware of by placing a big PFO closure device that's going to have impact, could be down the road with both sides of the closure, one on the left atrium, one on the right atrium. So I wouldn't really encourage anyone to be aggressive with PFO treatment or PFO closure. And I don't really think that as we stand right now in 2024, there's any clinical significance that we have to worry about, especially in the elderly patient population. Any questions about that? The other topic, any topic you guys would like to discuss? Chris,
I have something, Dr. Ibrahim.
go ahead, Richard.
Earlier today, we had a lady that we were contemplating an SVT ablation on, but she wasn't having long enough runs of it.
Right.
So, how long would a run would you need for to be ablated?
1 minute.
Okay.
I would like to see 1 minute of a run for us to be able to map and ablate. Anything short of 1 minute, I would try medical management to see if that's going to work. And certainly, if you're having 1 minute of SVT, that's not going to be of significant clinical importance for you to pursue intervention. And also, we really need to have at least 1 minute of runs of SVTs or any kind of heart arrhythmia to be able to do what we call activation map. Activation map, you try to move your catheter to see where the earlier coming from. It's AI kind of supported equipments 3D mapping system that we have. And this is how the way you do it. If you're going to have a few seconds run here, a few seconds run there, that's not going to be stable, which we struggle with that all the time in the EP lab. You can't map, and if you can't map, you can't ablate, and you really can't do much about it. So patient, as you remember, we saw today, she has a few seconds, irritating fast. It's really fast, as you saw.
Mm-hmm.
Um, but we don't know. The lady was, as you remember, 81 years old, so she's very sensitive lady to anything, and she's having some other symptoms. So we discussed that as of now we can't do anything. We can do loop recorder to see if there's any association between certain arrhythmias and your symptoms. And secondly, uh, if we think that there's only short episodes of arrhythmia like that, we probably need to do medical management, and ablation should not be in the picture.
Okay. Thank you.
Welcome. Any other concerns or questions, guys? All right, so I'm gonna do some refreshing about the antiarrhythmic medications, and there are certain stuff that you really need to uh, uh, to, to keep in your mind. In the classification of antiarrhythmic medications, there are classes of medication. There's a class 1, class 2, class 3, class 4. Class 1 medications, we have class 1A, class 1B, class 1C. We have class 2 medications, which are beta blockers, class 3 medication, calcium channel blockers, and we have a class 4 calcium channel blockers, and class 5, which is random adenosine and digoxin. Forget about all of that. What I really want you to keep in your mind two things. Number one is class 1C, anti-arrhythmic medication, what we call sodium channel blockers. Class 1C, you need to remember two things. Class 1C, remember two things, propafenone and flecainide. Always remember that you have to exclude two things. You have to make sure that the EF is about 50% for this medication, for these two medications to be used. And always remember, it should not be CAD or history of MI. Okay, no CAD, no history of MI, and EF is about 50%, then you can use these medications. HFpEF, you can use them because the EF is above 50%. So if the EF less than 50%, or you're not sure, or there's history of CAD disease or history of MI, or you're really not sure, I would really recommend for you not to use these medications because there's a black box warning based on the CAST trial in 1989, and they found patients were dying like crazy from these medications, and they found that medications, propafenone or flecainide, in the case of ischemic heart disease, low EF, they can actually cause proarrhythmia, and these arrhythmia can be these kind of arrhythmias can be lethal. So you can't use these medications. There are wonderful medications, can be used for PVCs, PACs, can be used for fast heart arrhythmias, they can be used for AFib, atrial flutter, SVTs, but make no mistake that if your patient having history of CAD, history of MI, or history of EF less than 50%, HFrEF. In that case, this medication cannot be used. The class 3 medications, the potassium channel blockers, we have sotalol, we have dofetilide, we have troniderone, which is Maltac, and we have amiodarone. Amiodarone can be used with all kinds of heart arrhythmias across the board. Problem is, it's a big gun. It's a big gun. So you need to make sure that this patient that you're using amiodarone on is not young, because it has cumulative effect. You know, if you're going to use higher doses for longer period of time, or small doses for longer period of time, that can give you symptoms or can give you complications or side effects from eyes, thyroid, lung, and liver. We usually use this medication, the amiodarone, for in pre-AFib ablation, during and after AFib ablation for a couple months, and stop it. We usually use 200 twice a day for a few weeks. You have to have 8 to 9 grams of loading dose in the liver to be able to have a steady state, medication steady state, and usually that takes some time for you to achieve that, because this medication actually goes to the liver and gets stored in the liver. So again, keep in your mind that the amiodarone should not be used in younger patients unless you absolutely have an indication, somebody who's on transplant list, somebody who is having VTs that they're not going to make it beyond 5, 6, 7 years. Otherwise, feel free to use this medication if you have somebody above the age of 80. The guidelines tell us that you have to do eye exam, thyroid exam, liver function test, and chest X-ray, PFTs every year or so. So at least do TSH, LFTs every year if you can. And then if you find changes in vision, then probably some kind of testing should be done. And if you have unexplained shortness of breath or lung symptoms that you cannot identify and your patient is taking amiodarone, that might be related to amiodarone. Okay? But it can be used everywhere. Now, if the other class 3 medication, which is sotalol, it's potassium channel blocker, can prolong QT interval, is actually excreted from the kidney, so you have to be careful with your GFR, and you have to adjust the dose based on your GFR. So if your GFR is 40 or less, in that case, you can use the medication once a day, or you can use smaller dose, which is 40 twice a day. If your GFR is okay, you can use the medication. We usually start 40 milligrams twice a day for a week, get another EKG, make sure that the QTC interval below 500, make sure to check your kidney function, then you can increase it to 80 twice a day and go from there. Medication can be used in patients with atrial fibrillation and CAD disease. I would not use it for decreased ejection fraction, and I would leave that for physician to decide, for electrophysiologist to decide. Sometimes we use it actually for cases of ventricular tachycardia in the setting of AICD shocks. But we have to really be careful about it because it's negative inotrope and you have HFrEF and decreased EF that might affect your heart failure symptoms. So always keep in your mind, you can use the medication, atrial fibrillation, EF should be normal for you, history of CAD, that should be okay. And you have to be careful about kidney function. Check, start small, very small, check EKG, and then go from there. The other medication, which is dofetilide, I would never start dofetilide. If patients of yours taking dofetilide, you have to make sure to check 2 things. You have to check chem panel to make sure your potassium, magnesium, and kidney function. Potassium, magnesium, and kidney function. And you have to get EKG to check QTC interval. QTC interval above 500. In that case, medication dose should be adjusted or stopped. Okay? Always remember when you measure QTC interval, if you have left bundle, right bundle branch block, you have paced rhythm, I would take about 80 milliseconds from the QTC interval. So, so if you measure QTC interval 460 and you have left bundle branch block, I would take 80 milliseconds. That's gonna make it what, 480. So that should be okay. Always remember to check kidney function, as we said, and dofetilide can be used in heart failure, HFrEF, HFpEF, can be used with CAD, without CAD. It's wonderful medication. It can be used for persistent atrial fibrillation. It's very powerful medication, but you really need to treat it with baby gloves. You have to be very careful about when to use it, how to use it. I will never initiate dofetilide by you guys. It should be initiated in the hospital. But if you have patient, don't get scared. Just make sure kidney function, creatinine is okay, QTc interval is okay, and maintain it. Dronedarone or Maltac is very weak medication. It fell out of favor, but you can use it for patients with atrial fibrillation and CAD disease. If your patient has a class 3 congestive heart failure or any admission over the last 6 months of heart failure, medication is contraindicated. In fact, there's a black box warning about this medication. If you have heart failure, class 3, doesn't matter, HFrEF or HFpEF, or if you have history of heart failure admission over the last 6 months. Maltac, heart failure, don't be used, should not be used. Now, I know that your probably 80% of your patients with history of heart failure, but if there is no admission because of heart failure over the last 6 months, patient does not appear to be in class 3 congestive heart failure. If they are class 3 kind of functional class because of lung disease, that's different. Class 3 because they are elderly and can't walk, that's different. But if you think that the class 3 coming because of congestive heart failure, then dronedarone should not be used. It's like amiodarone. It's much weaker, but it does not have iodine, so it does not have these kind of side effects of the eyes, thyroid, lung, and liver. Okay? Digoxin. We have a case. Was it you, Nick? Who discovered the digoxin lady had a digoxin level of 3 point something? Was Matt. Matt?
Yeah, the lady with moral, she had digoxin toxicity. You ended up
Yes.
putting a
Right.
pacemaker in her. We gave her Digifab.
Yep. Digibind. Yes, that's true. So we had a lady. Do you want to tell us about this lady? Do you still remember her?
So
I have a passion to dislike digoxin for a reason. And tell us
yeah.
about this lady.
yeah, it was a good reason. Yeah, because she was having, I think, runs of junctional beats, or no, idioventricular rhythm.
Right. Complete heart block.
And she was in the 40s at times. And we gave her the Digibind, and then even after the digoxin level went down to subtherapeutic level, she was still having a really low heart rate. So,
right. So we don't like this medication. She has a acute kidney injury. Her TSH was 116, extremely elevated. And remember, make no mistake, the digoxin is half-life, it's about 32 hours half-life, so it stays long. And these elderly people, they can get insult to their kidneys anytime. And in that case, you're not gonna get rid of the digoxin. Digoxin is gonna stay in the bloodstream. So when they called me initially and she was in the ER, I told them don't give her Digibind, just leave her alone. She was doing okay, complete heart block, blood pressure was maintained. The reason I decided to do the Digibind, if you might remember, she was having the ugly VTAC. Remember that? Torsades? So the big mimicker of heart arrhythmias is really digoxin. And whenever you start seeing not sustained VTs with digoxin toxicity, this is when you're going to use Digibind. We did use Digibind and, did not have much of VTAC anymore, but she continued to have complete heart block. And this is where we decided actually to go ahead and do the pacemaker on her. Since then, she did very well. In fact, when we saw her atrial tissue was so badly toxic to the point, intoxicated to the point that she has actually standstill atrium. There were no P waves created by the atrium. So that's a really typical digoxin toxicity effects. And this is why for your patients, try hard to stop digoxin on any patient you see, unless there is some other reason for them to continue, which I really don't see it. I've never seen it. So we use digoxin only in patients settings like let's say LTAC, such as PAM or Kindred, where you have a blood pressure of 90, heart rate of 150, and patient septic. In that case, you give them some IV digoxin for a couple doses and leave it alone to buy yourself some time for hydration and antibiotics to work. But you know, long term is just very, very, very bad, very toxic medication. So, and also there's another thing about that lady, Matt. Her when I started giving her IV fluids, her potassium went down to 3.6 or something like that, and she started having
Yes.
worse arrhythmias. And always remember, you have to keep your potassium level high in the case of digoxin use. Whoever works with me, they know that, you know, I ask them about two things with digoxin. When I start digoxin IV for a short period of time, I ask them about creatinine and I ask about potassium level, because potassium hypokalemia will exacerbate digitoxicity. So always remember that. Any questions about the arrhythmias, antiarrhythmic medications, about what we chatted about today?
I have one.
Okay, Nick.
Combining antiarrhythmic medication.
Yes.
What are okay to combine?
No, it's not okay for you guys. You have to remember that if you're going to combine antiarrhythmic medications, you have to have an ICD in place, and you have to have a medication that you're using which is becoming the arrhythmia is resistant to. Like for instance, if you're having VTAC and you start amiodarone, and then patient continues to have ATP therapy or shocks, then you can start mexeltine. I've used amiodarone and prokinamide a few times throughout my career, but I would never ever use two antiarrhythmic medications unless there's absolutely needed by physician. Initiation most of the time should be at the hospital, and patients should have AICD.
I have a question, Doc.
Yeah, Richard.
Guy we had this morning before you got there, history of cardioversion, was back into AFib after starting Sotalol 80 BID, and came in today. He was still in AFib, so I increased him to 120 BID, and I'm just wondering if he comes back and he's still in AFib a week later.
We need to shock him.
Shock, yeah.
Exactly right. We'll do cardioversion on him.
Okay.
Guided cardioversion, and see how he does on that. If that Sotalol doesn't work, then the next line is going to be dofetilide. So dofetilide is the strongest. Sotalol is reasonable. You don't have to be at the hospital most of the time to start the medication. But if that doesn't work, shock him, see how he does. Continue to have issues with AFib, then dofetilide will give him a shot. If the dofetilide works, we're good. If the dofetilide doesn't work, we have two options. If it is fast heart rate, in that case, we have to do AV nodal ablation by the pacemaker. If it's not fast heart rate, we just need to accept the rate control strategy, which is
Beta blocker.
be okay. Yeah, rate control, anticoagulation, leave him alone.
Okay. Thank you.
Any other questions, guys? Okay. All right. Well,
Hey, Dr. Ibrahim, it's Jackie.
hey, Jackie.
Hey, whenever you said you don't want us combining antiarrhythmics, you're fine with like amio and diltiazem combinations.
Right.
What are you?
Right. Actually, I meant to say our antiarrhythmic medication, let's say class 1, in general, 1A, B, C, and the class 3.
Okay.
You know, the Vaughan classification for antiarrhythmic medications, it included the beta blockers, calcium channel blockers, adenosine, and digoxin. But you know, we all know that the antiarrhythmic effects of the beta blocker, calcium channel blockers, digoxin, and the adenosine, which adenosine we don't use, we only use IV. These effects are very benign. They really slow the AV node and the sinus node activities. So they don't really affect the tissue conductive properties at large. and the heart. And this is why these medications do not have that much of pro-arrhythmic effect.
Okay.
The other medications, they do have pro-arrhythmic effects, such as sodium channel blockers or potassium channel blockers, such as the dofetilide, procainamide, mixiltin, sotalol, amiodarone, and others. And these medications should not be really mixed together. But that's a very good point.
Okay, thank you.
All right, guys, thank you very much. We will get together again in a couple weeks. Send us suggestions if you have any questions or suggestions, okay?